Our first speaker in this session about imaging models using animals is Kasper Kyng from Århus, from Rigshospitalet Hospital, where he's a neonatologist, and he's also a senior researcher, mostly working with MRI in animals, examining early injury in these animals. Okay, Kasper.
Yes, thank you. Can you hear me in the back? Thanks. So thank you for inviting me to come here today. As Helle said, I'm going to talk about neonatal brain imaging, a little bit about brain injury in the newborn and clinical imaging, and then working my way to why we use the animal models as well. So my disclaimer is that I'm not an MRI expert, but we do use MRI as a tool to evaluate neuroprotective interventions and to learn more about the brain. So for context, I'll talk a little bit about hypoxic-ischemic brain injury in term babies and the use of piglet models for improving management. I'll also talk about what's known from the clinical trials in human infants about how MRI and MRS can be used to predict later neurodevelopment. And then based on that, I'll move on to our studies and also just a little bit, I'll focus more on the methods rather than the results. So what's possible, what can you do with brain imaging in the newborn? Yes, so I won't be talking about preterm infants, which is its own story entirely. So hypoxic ischemic brain injury may lead to hypoxic ischemic encephalopathy, which is for any neonatal clinician quite a common condition. In the developed world, it's probably around 1 in 1,000 live births, and in third world countries or less resource-intensive settings, up to 20 per 1,000. So it's very varying. It's associated with morbidity and also a significant mortality, and is the most important cause of neurological injury in the perinatal period, and actually in terms of lives lost or quality of life, I think daily is the expression. It's one of the most significant diseases in the pediatric population as a whole. So encephalopathy on a hypoxic ischemic basis is sort of a slope from you can have hypoxia-ischemia around birth and no brain injury, or you can have very severe brain injury leading to death. On the right, you see some of the clinical criteria for treating the babies with therapeutic hypothermia. I guess the only population still really being treated with that. So for moderate and severe HIE, we cool the babies for 72 hours. So interpreting the outcomes is a little bit tricky because you can have infants without HIE that end up with brain injury for different reasons, or you can have infants with severe HIE that end up with a really good neurodevelopmental outcome. And then there are a lot of modifying factors along the way. Infection, we're studying a little bit how that affects also neuroprotective interventions and all these different things. So it becomes difficult to interpret. And the reason I'm mentioning this here is because we have to take that into account also when interpreting our MR images. So the timing for hypoxic ischemic brain injury, probably for any kind of brain injury in the newborn, is really important. So after hypoxia-ischemia, there are at least 3, possibly also 4 phases of brain injury. So there is the acute injury with necrosis, cell death, irreversible. Then there is a secondary latent phase before the secondary phase, which at least now is considered probably the best window for neuroprotective interventions, and therapeutic hypothermia, which is currently the only neuroprotective intervention in these babies, actually was developed in the piglet model, which is really nice because then we have sort of proven translatability. But that also changes the development of the brain injury. So there are a lot of different mechanisms going on in the brain and in all the other organs. Some of those are modified by hypothermia. Looking at different treatments, they'll probably modify other factors. So again, all of this is also going to affect our brain imaging and how we interpret different types of brain imaging. So why use animal models? So for any individual hospital, this is going to be a relatively rare occurrence, even though it's not very rare sort of worldwide. We also study more sort of clear-cut cardiac arrest models, which is also isolated for each doctor or each hospital, a rare occurrence. So in the animal models, we can reproduce those disease states. We can control at least many of the factors. For perinatal asphyxia, it's especially important that we can control the timing. So for a baby that's born encephalopathic, we never really know, was it just around birth? Was it in the days up to birth? Or was it in the resuscitation after birth? So in the animal model, we like to think that we can control also the severity of injury. This is actually quite difficult. I won't go into that today, but also they have biological variability. So it's good for testing new treatments. Ethically, it can be problematic to start directly in the babies. Also, increasingly, FDA and EMA require larger animal studies prior to going from smaller animals to clinical studies. For this reason, we get a lot of requests if we can test this and that in our animal model, and sometimes we do collaborations. Okay, so we've think a lot of animal studies. Histology is sort of the basic outcome. It's very difficult to do that in babies. So we've been very interested in MRI, because you can do MRI in a baby, you can do MRI in a newborn piglet. How well they correspond, I think, is an open question, but we like to think that we can at least compare our outcomes with MRI, more so than with behavioral or histology. Yes. Did I start 5 past, or just want to manage the time? Okay. So obviously in the animal models, we can look at stuff that we cannot do in the babies. So this is looking at microdialysis of glycerol. So the red curve is just normothermia, and the blue curve at the bottom is hypothermia, and controlled piglets with no hypoxia-ischemia. So we can sort of prove that hypothermia, for instance, works in this model, something we knew already, but it's also nice to compare stuff like this with our MRI. So considering the different outcomes for measuring brain injury, obviously this slide is not exhaustive, but one of the best prognostic outcomes clinically is actually the degree of encephalopathy on clinical examination. We can do that with the babies. We use it for the diagnosis, for initiating treatment, but it's not very good to evaluate treatment effect. It's a little difficult in the piglet model. The gold standard, obviously, is the late behavioral outcomes. How did it go when the baby was older? But in terms of conducting clinical trials, this becomes really long if you have to wait 2, 3, 5 years for an outcome. So tomorrow also you'll hear about the TOBI trial and diffusion tensor imaging, and trying to use also MRI as a clinical outcome for sort of speeding up testing of new treatments. So EEG and AEG also is used for diagnosis. It's not that good for prognosis. Isn't really used for treatment effect because it's an earlier test. We can do all of these in the piglet model. Advanced brain MRI, as you see, can be used in the piglet model, can be used also to evaluate both prognosis and treatment effects. And the parenthesis is because clinically, I think we need to up our level of feedback that we get from the MRI scans. So this is really the one that we put a lot of emphasis on. Okay, so what's known from the clinical trials? Because again, we're really interested in the translation. The animal experiments are only interesting to us to the degree that it also informs us about human biology. So the MARBLE study, I'm going to mention 3 MRI studies that looked at neurodevelopmental outcome and then the ability of an early MRI to predict the later neurobehavioral outcome. So the MARBLE consortium looked at 190 children. MRI was done on average day 7, and there was behavioral testing at 23 months, and they were looking at how well MRI could predict a good versus adverse outcome. And lots of different outcomes, busy slides. Just gonna ask you to focus on what's in the red square, which is that the best area under the curve, the best sensitivity specificity was for magnetic resonance spectroscopy of lactate NAA ratio, and also just looking at the NAA concentration. The Toby Xenon trial, which I think you will hear about tomorrow, looked at 92 children, and they did a nested sort of sub-study looking at MRI, MRS. These scans were done within 2 weeks, so pay attention to the timing also of the scans, because that's really important. They similarly found that lactate NAA, or the fractional anisotropy, and if you add them together, that was the best prediction. So this is a little bit about what's the state of the art clinically in terms of predicting later neurologic outcome. It's also a study from Japan, published in 21, looking at 98 children. They found that the total NAA was actually the best predictor. I'm getting a little lost because I'm too close here. So anyway, it's up for debate, I think, whether the lactate NAA ratio or just the concentration of NAA in itself is best, and obviously they're interlinked. All right. So this was sort of the what we knew before starting our piglet studies. We've been doing MRI in piglets for a long time, since I had hair. I think this is a 12-year-old picture or something like that. So this is a piglet in a 3 Tesla scanner. This is just showing you a little bit of the setup. So now we have an MRI scanner right next to the animal facilities, but prior it was like a 200-meter walk. So just to transport the piglet 200 meters, you need to get a lot of stuff ready. And they're sedated during the scan, speaking of motion artifacts, etc. So you also have to consider sedation, ventilation, keeping them warm is an issue, figuring out if they desaturate or get bradycardic. So anyway, the modalities that we've been looking at, not so much T1, T2 weighted imaging, but DWI, spectroscopy, also looking at perfusion. So I'll get back to these in the coming slides. We've been looking at BOLT for oxygen saturation, and we've just started looking a little bit at hyperpolarized MRI, which I'll get back to. And we are considering trying, and now this is why I said I'm not an expert in MRI. So anyway, QSM and MTSAT, which I'll also have just one slide for each to inspire you. So I think I could have given the whole talk just about all the issues. And obviously this is also a little bit seen from the point of a clinician. But planning your MRI protocol, your MRI sequence, you have to be really aware of what's the type of brain injury that you're looking at or expecting to be looking at. What's the brain regions that you will assess in relation to what type of brain injury? What's the severity of brain injury? Because for instance, for hypoxia-ischemia, depending on the severity, you'll have injury in different places of the brain and at different times. Also, what are the variations in the model, in the clinical scenario? So if you have a baby with sepsis, for instance, the correct or the optimal timing for MRI might be different than the exact same baby if there was no sepsis. If you treat with hypothermia, you see different things at different times. So each time there's something different, what you'll see in the MRI scan might vary due to timing issues and not only due to actual difference in brain injury. Yes. Also, technical issues. So, for instance, for some of the first scans that we did 10 plus years ago, when we got the lactate data from the spectroscopy, it almost looked inverse. So it's really important to go back and say, how come it's highest in the healthy animals and it's normal in the sick animals? And it turned out that, and it was really difficult to delineate, but our MRI people had a long chat with Siemens in Germany, and it turned out that the coil size relative to the piglet, there was some software that needed to be corrected, and then suddenly the results were flipped around. So I think you always need to pay attention, and there are so many steps that can affect your data, and it becomes a little bit of a trust as well. So also, if you're used to MRI in adults or older children, it's important to know that the tissue characteristics in the newborn brain are different. So relaxation times are different, post-processing is different. You have to really pay attention to voxel size, 1 voxel, 2 voxels, more voxels, echo times, I'll get a little bit back to that, and obviously motion artifacts that you heard about this morning. And I could have more slides with all those. So just for the basis, how an MRI scanner can make an image by first using magnetism to straighten all the protons and then look at the relaxation. You all know probably T1 and T2 images, which has formed sort of the basis also of the literature for hypoxic-ischemic brain injury in newborns. There are a number of standardized scoring systems for newborn encephalopathy and HIE. And what you saw, if you had time to look at the whole slides from those previous studies, is that some of these newer modalities perform better than the standardized scores that we know in terms of predicting later neurodevelopment. So this is what we know currently, at least, and it's being modified with new treatment, new sort of better supportive care, etc. All of this can change a little bit, but there are predilection places for injury after hypoxia-ischemia. And this is an example of the Rutherford score. I'm going to go over that. So basal ganglia is a typical place, the posterior limb of the capsula interna. And also, even with the older scores, there is a pretty good correlation between basal ganglia injury and CP. And I think now we're sort of moving on from that, so we don't use that too much in the animal models anyway. So diffusion-weighted imaging can tell you about the free movement of water, and then when there is edema that is restricted. Again, I think that it doesn't necessarily pseudo-normalize after 7 days. In the piglet model, it's a lot faster, probably depending on all these things I mentioned previously. That time frame can be different, but there is a normalization when the edema disappears. This is a very busy slide, but also just tells you what kind of diffusion changes are seen after HIE. So 25 to 75% have diffusion changes in the basal ganglia that we also saw in the T1 images. So you can have that even with a totally normal anatomical or T1, T2 MRI. You also get watershed injury. You can have global injury if it's very severe. And this is diffusion images of different conditions. I won't be going into DTI. I think David Edwards will mention that in a whole session tomorrow, but that's also based on diffusion. You can see tracts of myelin. So this is just then a few examples of what we did in the piglets. So I'm not sure if it's large enough for you all to see, but this is a cardiac arrest model in term piglets, where we just looked at adrenaline that's used for every cardiac arrest versus just placebo, so no adrenaline. A normal ADC, which is just a quantitative value of the diffusion imaging, in this model would be around 1,000. And these scans are done at around 14 hours. So less than 500 is quite severe edema, and it's even more severe with the placebo. So I think both of these groups of piglets are just really hurt, but it's a little better in the epinephrine group. So again, also when designing animal models, if you have a really severe insult, which this is, it can be hard to show a therapeutic effect because you need to be able to salvage some brain cells. This was an HIE study, also a little bit of a busy slide, but this is again looking at the ADC values in brain average, but also different areas of the brain. And this was an interventional study looking at remote ischemic post-conditioning for its neuroprotective properties. And the small group here is sham animals, so with no hypoxia-ischemia. And here's a normal sort of ADC of about 1,000 that I mentioned. So on average here, there was no difference, but these scans were done at 72 hours. And if you look here, at least in this piglet model, and this is without hypothermia, it would change if we had cooled these piglets. The black one, we'll just look at the DWI now. The black one is the sham, and then we have piglets that were scanned on day 1, 2, and 3. So we see severe diffusion restriction at day 1, actually in all of the brain, but already at day 2, there is normalization. So this was a lot quicker than 7 days. So if you only scan at 72 hours, you think nothing is going on. But if you then look at piglets that were scanned at 24 hours, it's a whole different picture. For MRS, this is lactate NAA ratio, shams here with the lowest ratio, and then you have a less clear picture, but it seems to be a little higher maybe on day 1 than on day 2 and 3, but this was not statistically significant. So just an example. This is from the Japanese clinical study, also looking at total NAA versus ADC values, which were the diffusion parameters. And this is then postnatal hours here. So you see that the total NAA, and these are the good outcome versus the bad outcome, so the total NAA stays low, whereas in the poor outcome group, the ADC values actually increase. So if you do your MRI here with diffusion-weighted imaging, you're not going to see a difference between good and bad outcome. So MRS. Phosphorus spectroscopy not used so much anymore, to my knowledge, anyway. So proton spectroscopy can give you these shifts depending on the at least relative amount of different metabolites. And notice here that peak can also be negative, but just pay attention to this negative lactate peak. So this was the same study with remote ischemic post-conditioning MRI, MRS at 72 hours after hypoxia-ischemia, and looking at lactate NAA ratios, which we chose as the primary outcome based on the clinical studies mentioned before. And there was a little bit lower lactate NAA ratio in the brain average and the basal ganglia with treatment. Then we also did a milder insult, and just the take-home message here, I don't think you can see it, but this was also looking at lactate NAA ratios. This time it's a logarithmic scale, but basically with a milder insult, the same treatment and also hypothermia. There was no additional neuroprotective effect based on the lactate NAA ratio with remote ischemic post-conditioning. So also the degree of the insult, that's why I took this slide, is going to affect your MRI parameters and treatment effects. Then another technical thing that we've tried to improve, and it's very important, is that you want the best possible signal-to-noise ratio. And the echo time is one of the factors that's really important. So this is from sort of a summary paper by Linda de Vries, which is one of the grand old MRI women. And this is the lactate peak with a short echo time and a higher lactate peak and a better signal-to-noise ratio with a longer echo time. This is from her paper, but we see the same in our own data. So this is with an echo time of 135 versus 288. And here you see the NAA peak, but you don't really see much of a lactate peak. And this is the same piglet scanned just after. With a different echo time, you see a much clearer lactate peak. So there are a lot of technical aspects going into interpreting your data. The newest thing, to my understanding, in terms of spectroscopy is that there is a different technique software-wise that's called laser rather than press that gives also less motion artifact and better signal-to-noise ratio. So now we're trying to use laser. Does anyone here know the difference between press and laser? Sure, the physicists maybe. Okay, so I'm not no one raised their hand, so I'm not going to raise mine either. So, but we just talked about motion artifact, so I think just in relation to that, it's really important that there are many aspects that can affect that. So I have 7 minutes left, it's perfect. Arterial spin labeling, which is a perfusion measure that you can do with MRI. So there are different ways that you can try to measure cerebral blood flow in neonates, and there is no consensus on the best technique, the correct timing, how to interpret it. So ASL is one of those. So you can do Doppler, ultrasonography, you can do NIAS, you can do MRI, a number of other stuff I'm not going to go into. But here again, acquisition time, motion artifact availability are some of the cons for the MRI. Yes, and again, I think this one is really important, regional versus global estimations of cerebral blood flow. So again, if you just do one voxel at one point in time, you may see higher or lower diffusion, and you may not even know if you think back to that slide with the timing evolving brain injury, you don't even necessarily know if higher perfusion is good or bad. So it becomes difficult to interpret some of these measures, because some of the things might just be a physiologic repair process that's really protecting the brain. So anyway, ASL can sort of subtract, so you can spin label some of the blood going up to the brain, and then you can subtract the labeled image from the basic image, and then you can get an idea about perfusion, and depending on the time delay in different brain regions. This is ASL also from this review paper in a healthy infant and HIE with an adverse outcome and hyperperfusion. So again, timing is going to be really important. So we're interested also in brain perfusion. That's the ischemia part of hypoxic ischemic brain injury. And some of these neuroprotective interventions we think might act in part also via preserving the circulation. So we looked at arterial spin labeling also in our piglet model in this HIE model, and we actually found that with post-conditioning there was perfusion that was higher and more similar to the healthy sham animals than with just hypoxia-ischemia. This was without therapeutic hypothermia. And we saw that in whole brain, but also in basal ganglia, thalamus, and cortex. Then we also looked, and our scan time for all of what I'm presenting here is up towards 45 minutes and in anesthetized animals. So we're not doing 2 hours, but it's also not taking 15 minutes. So bold imaging, you can assess local differences in oxygenated and deoxygenated hemoglobin. We also found that there was higher T2 values with post-conditioning in basal ganglia and in whole brain, but then not necessarily in all brain regions. This is bold from the cardiac arrest model. So not statistically significant. These are quite few animals that had a scan done, but it seems just based, I guess, on this outlier to be higher in the placebo group. Then, you know from PET scan that you can visualize the metabolic processes, so also the MRI people are starting to look at that. And one thing you can do is that you can hyperpolarize C13 atoms. Then you have to run from the machine to the patient or the piglet because it deteriorates really quickly, but then you inject it. And this is just from sort of a methods paper, but then anyway, you can have puree that's labeled, and then you can see how much becomes lactate, how much becomes bicarbonate, how much becomes alanine, and then you can follow theoretically different physiologic processes. So this is work done by Ted Andelius, who's a postdoc in our group, and Christopher Larsen, who's an MRI professor, and this is unpublished data so far. But they and we tried this in the piglet model, so more sort of a proof of concept. And we found also that we could see differences in the pyruvate metabolism. So this is just a 2-minute time course in piglets with and without brain injury. And this is also from the hyperpolarization data. You can see that the metabolic ratios change after hypoxia-ischemia. So this is, I think, MRI sort of trespassing on the PET area with no radiation. So just the last couple of slides. MT-SAT is a method that we have not been using ourselves, but basically you can look at myelination, you can look at tissue microstructure, and it's not a new technique, but I think it's just recently been applied in human neonates as a proof of concept, but also you can find different animal publications that they use this to look at myelination in different disease models. And QSM, which essentially can, I think for practical purposes, you can quantify non-heme iron, but you can also look at different biometals molecules, including also calcium, lipids, myelin. And there are some also more, I think, proof of concept studies that at term equivalent, you can see differences between preterm and term born infants. So that was it. These are some of the people in our group. Yes. Thank you.